Whilst offered the opportunity of the Employee Assistance Program, William decided to go to his GP. The GP is a trusted family GP that he's been going to for many years and feels he has a strong relationship with, where the GP listens and is supportive. And indeed, about 75% of people who seek help for a mental health problem go to their GP in the first instance. In William's case, the GP is Dr. Hope, and I'm wondering if Dr. Hope could share with us some of his insights from his many years in practice around some of the issues people present with and how you might tease out and offer assistance to patients when they come along for help to the GP.
Thanks. Well, this is certainly an unusual thing for Bill to come in with. He usually comes in for his regular checkups and the odd sprain and stuff, but this is quite different, and I've really never seen him like this. And what he's talking about is the way that what really was quite a healthy sense of self within his workplace, quite a positive, engaged place, is starting to feel increasingly hostile, increasingly he's feeling like he's not performing, and that goes along with this change and increase in responsibilities. As the GP, you've got to do a whole lot of things in this consultation. You've got to keep an eye out for major kind of psychiatric problems. You've got to be wondering whether this response to the workplace is paranoid. You've got to be wondering whether the 2 new Beamers are a sign of mania and he's overspending. You've got to be wondering about whether there's actually a depressive disorder or something. But probably none of those will actually turn out to be really there when you actually go through the kind of diagnostic rules. And probably really what you've got is a stress response. You've really got something that is very likely to be about someone who's in a new and more stressful situation, a different situation which their coping strategies are not really up to, and so they're foraging around trying to find different ways of coping, often some quite unaccustomed coping ways. And so, and some of those are productive and some of them are not. In this case, probably quite a lot of them are not. And so what you've really got to be doing is to try and work on the person about actually understanding what the stresses are they're under, looking at what their coping strategies are, reinforcing the positive ones, trying to actually encourage them to find some other ways in relation to the negative ones, and maybe supporting them in relation to advocacy for what could be done to actually improve their situation and get them some of the supports that they need. So it's likely that Bill would come along in this kind of situation, maybe with a complaint about the feeling of stress, about the sleep disturbance, maybe about the irritability, maybe about a loss of sex drive, maybe headaches, all of these kinds of things, which you would then proceed to talk about, and you would immediately, of course, open a can of worms. You might need to schedule a second consultation or some more to follow that up. You might run some fairly routine blood tests or investigations, which partly would be because there's some reasonable things to check out physically, but also would be a reason to bring Bill back and meet up again and have a longer consultation and talk the whole thing through. And so I guess what you'd be looking at would be you'd be trying to get to an understanding of all of this. And one of the key things that you'd hope Bill would come out of the interaction with would be a sense of understandability of the situation that he was in, and some kind of a sense of actually what the triggers were and what the things were that were perpetuating it. And out of that would be likely to emerge some kind of an action plan. And then you'd, in a sense, track and follow that through, and you'd be constantly monitoring it to see whether or not he would then actually head off in the direction of developing something that was more clearly a formal psychiatric disorder. But actually in this situation you would hope that with the right kind of supports and the right kind of engagement and maybe some shifts and changes in the workplace, and with some mobilisation of some supports, getting the communication sorted out with the wife, etc., that you would actually preempt that, and that hopefully from this rather kind of diffuse, mixed picture, things would actually pick up and you'd find that he'd get some supports and get something more back towards a sense of normality and back towards coping with this increased responsibility.
Thank you. The consultation with Dr. Hope was a particularly useful one for William, and he decided to follow up on some of the recommendations that Dr. Hope made to him, and as a result of that, needed a couple of hours off work for about a period of 6 to 8 weeks while he could do the follow-up for the external treatments that he required. William went back to George and discussed his needs, because it was now clearly identified that it was a health problem that was producing a performance-related issue. And George wanted William to be successful because he knew him well and saw a lot of potential for contribution to the company and to his own personal growth. So there was a period of time where twice a week he went to work an hour later. George discussed it with the team that there was William had a few issues he was addressing at the moment, and on Tuesdays and Fridays he was going to be in at 10 instead of 9. Dr. Hope was not one of these practitioners who likes to sign people off work for 6 to 8 weeks at a time because it's quite unnecessary, but wanted to support him within the workplace because stressors can be managed, and sometimes being away from work is the most harmful rather than the least harmful passage.